Faith Forward Media, this is Healthcare Musings. I'm Dr. Hassabolus. Welcome to Healthcare Musings. Happy to have you with me. All right, so you have a patient with septic shock, and you are either in the process of Dr. Hassabolusing them, or you have already Dr. Hassabolus them with at least 30 mLs per kilo, and the blood pressure continues to be low. You know, they have persistent shock despite adequate volume resuscitation, or, as I like to call it, Dr. Hassabolusing them. And so you need to start vasopressors. And typically it's norepinephrine first. Sometimes it's dopamine. Sometimes it's epinephrine. Sometimes it's phenylephrine. You need to start vasopressors. And so the question is, when you put the order in, what is the target pressure to which we need to titrate these medications? Sometimes it's a systolic of 90 or 100, and most of the time, or many times, it's actually a mean arterial pressure of 65. Is this good, though? Can this cause harm? Is this effective? And again, kudos to the pulmcm.org Substack, Dr. Matt Hoffman, fantastic Substack. Everyone should subscribe to it. He highlighted or brought to the fore literature that shows that targeting a mean arterial pressure of 65 may actually be associated with harm. So there were two meta-analysis studies, and in the one meta-analysis, patients assigned to a lower mean arterial pressure target had a risk ratio of 0.93 for 90-day mortality, but that was not statistically significant. This was a 7% relative risk reduction, and it was about a 2% absolute risk reduction in mortality. There was another meta-analysis performed or published in 2024 that combined 12 randomized trials, and they found that there was a 1% absolute lower mortality risk and a 7% relative risk reduction that was statistically significant. They also found when you target a lower mean arterial pressure, they had lower rates of atrial fibrillation and fewer transfusion requirements. So it seems that actually targeting a lower mean arterial pressure, maybe just 60 as opposed to 65, may actually be of benefit, and targeting a mean arterial pressure of 65 may actually be harm. Now, why would this be? Well, in distributive shock, the main hallmark of the pathophysiology is massive vasodilatation, right? And if you look at the blood pressure, the diastolic pressure is way lower than it normally is. So you'll have a pressure, for example, 75 over 25 or 80 over 30, right? That wide pulse pressure, that low diastolic pressure is indicative of massive vasodilatation. And so in order to get a mean arterial pressure of 65, you really have to crank up the doses of the vasopressors to get that systolic number high enough to achieve a mean of 65. And when you ramp up the dose of vasopressors, that's where you get all the side effects, right? That's where you get all the adverse effects. And so this literature seems to suggest that if you target a lower mean arterial pressure, the patients may actually do better. And in fact, I have started to do that in my practice. I've started to target either a systolic of 90 or a mean of 60, depending on the situation. And I've actually found that this has been successful, and patients have not done worse. And so, for number one, I'm in the aggressive camp. You got to Dr. Hassabolus them enough medication. And if you need vasopressors, it seems that targeting a lower mean arterial pressure, maybe a mean pressure of 60, may be good enough and won't cause as much harm as targeting a higher mean arterial pressure. Thanks again to the pulmcm.org Substack. Everyone should subscribe. And it looks like maybe targeting lower mean pressures in septic shock with vasopressors may be a good thing. Thanks so much, guys, for your time and attention. And until next time, Dr. Hassabolus signing off on Healthcare Musings. Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.